I'm Elizabeth Morrison-Banks. I'm a neuroimmunologist with the Connect MS project, and I'm going to be presenting a series of videos about multiple sclerosis. The first video will discuss the epidemiology and clinical presentation of MS. Multiple sclerosis is the most common cause of non-traumatic disability in young adults, and it's important to diagnose it early to start treatment so as to slow or prevent progression of disability. MS affects more than 400,000 people in the U.S., more than 2.5 million people worldwide. Most are diagnosed between ages 15 and 50. Most at diagnosis have a relapsing remitting form of MS, and most are female, but not all, and European ancestry is the most common, but as you'll see from the next slide, the worldwide distribution of MS involves every country in the world, and MS affects people from every walk of life. At the time of diagnosis with multiple sclerosis, approximately 80% of people have a relapsing remitting form of MS, and the other 20% have a form of progressive MS. There are multiple potential triggers for MS: infectious agents, environmental factors, genetic causes that combine to create an abnormal immunologic response that results in multiple sclerosis. The pathogenesis of MS isn't fully understood, but involves inflammation as well as axonal damage, and this affects both gray and white matter in the brain and spinal cord. I think it's helpful to think of MS with the analogy of an iceberg, that what we see at the surface, relapses, physical disability, other visible symptoms, are just the tip of the iceberg, but underneath the surface, people can be, sometimes from very early on in the disease course, experiencing cognitive impairment, MRI lesions, and other symptoms that are important to find out about. MS has been categorized in various forms: relapsing remitting, secondary progressive, primary progressive. I think sometimes it's helpful to think about MS in terms of larger categories of relapsing varieties and progressive varieties. The bottom line is MS is more than a demyelinating disease. It can cause permanent brain atrophy and axonal loss. Multiple sclerosis symptoms are quite variable among individuals. Some of the more common symptoms include fatigue, bladder and bowel dysfunction, sexual dysfunction, cognitive impairment. Depression is quite commonly reported. Numbness, tingling, weakness, impaired balance, vision changes, pain. Lermite's phenomenon is a tingling, shock-like sensation down the spine, usually experienced when the neck is flexed. This phenomenon is not pathognomonic of multiple sclerosis, but in the right clinical context, it can suggest demyelinating disease. The hallmark of demyelinating disease is a series of neurological changes that are disseminated in time and in space. Some of the red flags for demyelinating events include partial or full loss of vision in one eye or in both eyes, which might indicate optic neuritis, or trigeminal neuralgia, which is a lancinating facial pain. Some of the symptoms that suggest an alternate diagnosis other than MS include arthritis, which suggests an autoimmune or infectious syndrome, blood clots or recurrent miscarriages, which are suggestive of vasculopathies rather than MS. Hearing loss is not common in MS, and when present, suggests conditions such as Suzak's or Cogan's syndromes, among others. Patients who have heart disease or other vascular risk factors sometimes have ischemic vascular disease, and that should be considered in the differential diagnosis. And in those who have lung disease, we should think about sarcoidosis or other autoimmune conditions. It's important to diagnose MS early so that treatment can be started to slow disease progression and lessen long-term disability. If treatment is started at the time of diagnosis, the overall disease course is more favorable than if treatment is started later. MRI studies are very helpful in the diagnosis of MS, and some of the sequences we particularly look at are the T2 flare sequences to look for white matter lesions in particular, as well as T1 sequences looking for so-called black holes, which indicate axonal loss. Common MRI findings in multiple sclerosis include white matter lesions, which often appear as discrete, ovoid hyperintensities on T2 sequences. These are often periventricular and or juxtacortical in location. And on sagittal view, The white matter lesions may fan out from the corpus callosum in what we call Dawson's fingers. Then on T1 sequences, we may see in multiple sclerosis so-called black holes, which are indicative of axonal loss. These are the McDonald Diagnostic Criteria for MS, which were revised in 2010. The diagnostic criteria are quite complex and involve the clinical presentation, MRI findings, and other studies. Unfortunately, there's no single study that makes the diagnosis of MS. So diagnosing MS requires that we show that lesions are disseminated in time and space. We have to rule out non-MS etiologies or better explanations of the symptoms, and then we also have to obtain supporting evidence from MRI and other studies. The differential diagnosis of MS includes clinically isolated syndromes such as transverse myelitis, optic neuritis, and others, acute disseminated encephalomyelitis, neuromyelitis optica, or Devick's disease. There are a number of other conditions that can cause white matter lesions on MRI, including hypertension, migraine, Lyme disease, HIV, sarcoid, and others. There are inflammatory and infectious conditions in the differential diagnosis, such as lupus, neurosyphilis, progressive multifocal leukoencephalopathy. Developmental and other conditions can mimic MS, such as an Arnold-Chiari malformation, even vitamin B12 deficiency, or toxic exposures. At the time of diagnosis, we naturally spend time answering patients' questions about MS. And we can let people know that, in general, MS doesn't greatly decrease life expectancy. It's not a contraindication to pregnancy. There are very few pregnancy complications from MS, although MS attacks classically do occur postpartum. Exercise is beneficial and encouraged in people with MS, and I like to let people know that, in general, only about 1 in 4 people with MS will ever need to use a wheelchair in their lifetimes, and only 1 in 2 will require a cane. But I do let people know that to further improve those numbers, everyone who's diagnosed with MS should consider early disease-modifying therapy and stick to it. In the next video, we will discuss MS disease-modifying therapies.